After years of failed clinical trials, we finally have an approved therapy for geographic atrophy, and more hopefully on the way. But how are you going to integrate all of this into your clinic? I'm Rebecca Hepp, Editor-in-Chief of Retina Today, and you're listening to New Retina Radio, brought to you by Retina Today and Bryn Mawr Communications. Today, we are talking with a panel of experts about the introduction of GA therapies into the retina clinic. Joining me as our moderators are Drs. Alan Ho and Bob Avery. Alan, Bob?
Thank you for the introduction, Rebecca. I'm Alan Ho. I'm director of the Retina Research Unit at Wills Eye Hospital in Philadelphia, and excited to be here with some experts and friends and colleagues regarding this new treatment approved 6 weeks ago, but commercially available just over 4 weeks. So we're looking forward to their insights. Bob?
Yeah, it's an exciting time, and I'm thrilled to be part of this panel. I'm Bob Avery, founder of California Retina Consultants here in Santa Barbara, California. And let's start off with a brief introduction from each of our panelists. Eleonora?
My name is Nora Ladd. I'm a medical retina specialist and researcher on dry AMD here at Duke Eye Center. I direct ophthalmology clinical research at Duke, and along with Jeff, I served as a lead PI for one of the registration studies for this geographic atrophy treatment.
Hi, I'm Jeff Heier. I'm the director of the Retina Service and Retina Research at Ophthalmic Consultants of Boston. And as Nora said, we had the privilege of being co-chairs of the steering committee and PIs of the Derby and Oak studies.
I'm Dilsher Dhoot. I'm with California Retina Consultants, Santa Barbara, California. And we were also honored to be part of this trial, Oaks and Derby.
Thank you, guys. Thank you for taking the time. Our listeners and our viewers in the print publication are going to be very interested in your perspectives, considering your experience with Syfovre, pegcetacoplan, in patients with geographic atrophy. And it is a milestone in the sense that we've had clinical trials for geographic atrophy that have failed with complement modulation. So it wasn't really clear as to whether or not modifying the immune pathway, the complement pathway with C3, that was going to work. Further, this conversation with patients is very different now that we have an approved treatment, in that we're simply slowing progression of disease. Let me ask Jeff to start and just say a little bit about what you talk to the patients about and who you talk to the patients about when you have this in your toolbox.
Yeah, so I think, as both you and Bob started out by stating, we're excited to have something to offer these patients. You know, when patients presented 15, 20 years ago with wet AMD, we talked about not having something, and then we had the explosion of the anti-VEGF era, and we were able to offer these patients really nothing short of remarkable treatment in being able to control the disease, and in many patients improve vision. But shortly after that, we all recognized that dry AMD was an ongoing problem. It was a debilitating, unremitting disease that was going to take care of their central vision in a negative way. And so the approval of Syfovre as the first FDA-approved agent to treat dry AMD is an important step in our ability to control this disease. I tell patients that we do now have an FDA-approved therapy, that this therapy has a modest benefit in that it's a first step in being able to slow the rate of progression of geographic atrophy. It doesn't stop it. It doesn't reverse it. And even with treatment, patients are going to notice that they still lose vision, but they're going to lose vision at a slower rate than if they did nothing. And as we talk about the type of patients to treat, in many patients, the earlier on that we capture their geographic atrophy, meaning if we're able to capture it before it involves the fovea, we're able to capture it before those multifocal lesions coalesce, we may be able to have bigger impacts on the patient's outcome.
I have a question for the panel. What about patient selection? Is this drug for every GA patient who walks through the door? Or should we be more discerning in its use? I think this is something we have to apply the art of medicine to, because the label is quite broad, but I certainly don't offer it to every one of my patients. But I'd like to hear from the panel, who is the ideal patient and who are you offering it to?
Excellent question, Bob. So first, I'd like to agree with what Jeff has said and to highlight that GA is truly a huge unmet clinical need, and we haven't been fortunate enough to have approved treatments until recently. Again, pegcetacoplan does not stop or reverse the disease, but it slows disease progression. The effect is very meaningful because it preserves the cells in the retina responsible for vision for longer in these patients. And the protective effect of the drug, we know, increases with longer duration of therapy in this disease that's chronic. It works best when applied earlier, before the disease affects the foveal center. So I would think about that when recommending treatment for patients. I would take into account the fellow eye and whether vision was lost there, but then I keep in mind that extrafoveal lesions benefit the most. And then I'll have a full conversation about how nearly all medicines have side effects if they work. I will also explain to our patients that one of the potential side effects is potential conversion to the wet form of disease, for which we have excellent treatments. Otherwise, the drug was shown to be safe and well tolerated. But yes, patient selection will be part of the art of medicine. We have to take into account their comorbidities, ability to come in for frequent injections and how frequent, monthly versus every other month, and definitely the status of the fellow eye.
The label is indeed broad. I would say surprisingly broad, in that there are no restrictions for size, there are no restrictions for location, there are no restrictions on patients who have concomitant wet AMD in an eye with atrophy, which is actually, when I think about it, maybe a sweet spot for me for patients who have had chronic anti-VEGF injection to control their wet disease, but are starting to decline from atrophy. Dilsher, regarding selection and how you speak to patients, what's your perspective on this, since we do have basically broad guidelines?
Yeah, I actually applaud, the FDA's decision to make this label broad. I mean, this study was a large trial with a very heterogeneous population. And the majority of patients are actually foveal in Oaks and Derby, which is very interesting. I don't think it's for every patient, but it's remarkable how many patients are aware of this drug already. Whether it be through the direct-to-consumer campaign or whether it be from the news outlets. And so I've already had many patients asking about this drug, whether or not I think that they're a candidate. So it's almost important to discuss, with all of our AMD patients or all of our AMD patients with the GA. Who might be a good candidate or not. But I agree with the other comments. If we can start this early in a patient, it seems that those patients are going to have the greatest benefit. Patients with center GA, with very low vision likely are not going to benefit, though in the trial, patients could be enrolled up to 2320 vision. And so, generally, if a patient's much worse than that, I don't think that they'd be a great candidate. But I mean, I'm offering it to a wide variety of patients just based on the trial. Some of those inclusion-exclusion criteria that were in the trial. If I see patients that have that perilesional hyperautofluorescence or documented growth of GA, I think those are also good candidates for this drug.
If I can say one thing, it's interesting. I have exactly the same approach that Nora and Dilsher described in earlier patients, foveal sparing. But I had a patient today who came in and said, well, I have geographic atrophy. Why wouldn't you think I'd be a good candidate? And I said, look, you've already had central involvement and this isn't going to help your central vision at all. And they said, well, isn't this going to slow the growth of what I have? And I said, well, certainly that's what the studies have shown. He said, well, isn't it an advantage to have a smaller central lesion than a larger central lesion? And I, the patient brings up a good point. We've certainly seen patients with bilateral disease with 2400 lesions, but one is, 2 disc areas and one is 6 disc areas and is the 2-disc area better. And so I haven't started offering it to those patients yet. We're moving sort of in a slow, piecewise manner, but that patient brings up a strong argument.
And on the theme of broad label, we have data sets that are speaking to about every month or every other month therapy, and the label allows us to treat every 25 to 60 days is what's noted in the label, I believe. How are you guys going to decide what the right interval will be, and how would you mix that schedule with, say, a patient who is getting treatment for wet AMD concomitantly?
For me, I think that, with time, we'll probably have a better means of risk stratifying these patients. It's possible that this will happen with, the help of AI. But for now, I generally am favoring the every other month dosing for really 3 reasons. The first reason is efficacy. The difference between every month and every other month dosing was small, on the order of 3% at month 24. 17% in the every other month group versus 20% reduction in lesion growth in the monthly group. And so this difference is not that much for me. Second is burden. The loss to follow-up was less in the every other month group. It was 21% in the trial versus 31% in the every other month group at 24 months. And so this is going to be larger in the real world population. So I think that, making a more palatable dosing scheme from the start is probably most prudent. And then finally, safety. I felt that the rates of key adverse events were lower in the every other month dosing group, such as CNV onset or optic neuropathy. And so for those reasons, I think I also favor the every other month dosing group. But there might be patients that are high risk with documented, rapid GA growth, that's parafoveal, and they may opt for, monthly or even every 6-week dosing. And so, but I think the majority of my patients for now, I think I'll begin with every other month.
I agree with all these considerations. In the end, though, as Jeff's case points out, I think a lot of these decisions will be patient-driven, and we'll have to have thorough conversations about all these issues and all the points you brought out. And we also have to keep in mind that these GA injections will add to our large volume in our clinics. Also, if a patient converts to neovascular AMD, the decision will need to be made how to give the 2 injections, either on the same day, 30 minutes apart as in the trials, or on separate days, depending on clinic flow and patient-physician preference. But I think patient preference will be a key factor here. And there'll be patients that'll be very motivated to slow down their disease progression, especially if they lost the other eye, or if they really feel that the disease is encroaching or the center of the vision or impairing their peripheral vision, as Jeff's case illustrated. So they might be very motivated to have monthly injections despite the data presentation, as you mentioned, Dilsher. So I think we'll have to have a lot of chair time up front and discuss all these considerations and make a joint decision about all these issues.
I agree completely. For me, I think the main component that's going to drive my decision is the safety. And where, as Dilsher noted, the efficacy is relatively close. There are clear benefits seen in the monthly over the every other month, but the safety is also clearly better in the every other month than the monthly. When you look at the rate of CNV, roughly 12% versus 7% at 24 months versus 3% in the sham group, and the ischemic optic neuropathy, which were clearly more prevalent in the monthly versus the every other month. I think for most patients, the safety is going to drive that decision. But as Nora said, there are certainly some patients who are going to be extremely motivated to have as big an effect as is possible. And those are probably the patients that you would put on monthly dosing.
Jeff, I think those are very important points. I agree with what everyone has said. And I've been a bit more focused on the interischemic optic neuropathy when I realized that there were 7 patients in the every month group and 1 patient in the every other month group and 0 patients in the sham group, all groups about 420 patients in size. And that somewhat of a, if you want to call it a dose response curve, concerns me until we know more. And so personally, I've been offering it on an every other month basis in my population, just based on that, observation of 7 versus 1. I don't know that that's going to hold out. And these were not all severe. Only 3 of the 8 were severe cases, SAEs. And so it may be overkill, but that's pushing me towards every other month, given the efficacy doesn't seem to be that different, as Dilsher pointed out. And as you said, safety is paramount in this sort of scenario, because the ideal patients are typically monocular. They've lost one eye from GA, and they're seeing something in the other eye, either on the monitor or seeing a visual field loss. And those are the ideal patients to sign up, because they're motivated. And yet I would hate to have a hand in creating a problem for them, as a side effect and unintended consequence. And so I've at this point headed towards every other month dosing. Any other comments in that regard?
Yeah, I do it from what I understand, it does appear as if these patients are largely patients with discs at risk. But still, there's as you said, it's 7 to 1 in the monthly versus every other month. So while there may be characteristics that you can be aware of and look out for in treating these patients, the safety of the every other month looks quite good.
And the dose response is definitely something to think about. And that's why I brought up the exudation and the higher likelihood of that happening in patients on monthly injections, and then that adding to our injection burden in clinic, and also to the patient burden to have 2 injections in one eye. So I would favor every other month dosing as well in the majority of my patients, unless they're really motivated to have the monthly. And also we'll discuss the optic neuropathy cases and those data that are very important.
Dilsher, I have a question for you, since I know you pay attention to billing. How are you going to handle those wet patients who also have GA? Do you plan on doing the injection on a separate day for the wet disease? And if so, are you concerned about having 2 injection codes for the same eye within a sort of a 28-day window? Do you think that may trigger some of our Medicare Advantage plans algorithms to reject your claim?
Yeah, I'm actually very concerned about that. I think that, there's a high chance that, in the beginning here, we will have rejected claims. And so I think we have to be cautious about how to proceed here. There unfortunately are many patients that require treatment for both GA and CNVM. And in the absence of these payer issues, I would be perfectly comfortable injecting them on the same day. Perhaps waiting, 15 to 30 minutes between the injections, maybe starting with the anti-VEGF injection since that volume is less, and then proceeding with the GA drug. But I'm hoping that there will be guidance, and I'm optimistic that, over time these things will work themselves out so that, we can code and be paid for the injections on the same day, and also within a 28-day window.
The safety discussion is obviously, from the patient's point of view, something they rely upon us for. And we have a data set that includes 12,000 injections, which is a large number of injections, but not a large number of patients. If there are 1 million patients with GA in the United States and several million or 5 million throughout the world, I think it'll be important for our community to be vigilant in monitoring for the safety issues that we come to see when new products are introduced to the market. For example, all the biologics that we've seen in the anti-VEGF era have gone through little perturbations in their safety profile, where we've seen intraocular inflammation or this kind of thing. We have not seen ischemic optic neuropathy. So that's something that I don't understand and prompts pause for me, especially in light of the fact that these might be the vulnerable patients with only one good eye. And you're thinking about this in a patient with not non-center involved geographic atrophy. But I think an important message for our listeners and our readership is that we should be vigilant and use organizations and systematic reporting like the ASRS REST committee to keep tally. We owe that to our patients for sure.
Yeah, I think you highlighted the ASRS REST committee, and that committee has really been invaluable to retina specialists to helping to pick up early on signals that as individual practitioners we might not pick up. So I echo your comments that it would be very helpful to report anything of any of the drugs to the REST committee.
And I'm not calling out or calling out potential potholes, but I think, from my perspective, as the first approved geographic atrophy treatment for significant major disease, I think that I think this is a real milestone as we let off. I think just like with anti-VEGFs, we started with anti-VEGF 1.0, then moved to 2.0. Now maybe we're at 3.0 with combination therapy. So I think I'm very happy that this is approved, and I hope that others will be as well. This allows the ecosystem to continue to invest in new treatments in this condition.
But it, I would point out that, a lot of people are concerned about the minimal efficacy of this agent. And just as you mentioned, Alan, it is a milestone because we've had major failures. I can't tell you how many people I've told something's on the horizon for their GA, only to see lampalizumab fail and others fail, and everything get delayed. And I've had a lot of patients that I've been promising something on the horizon for quite a long time, and it's great to finally be able to give them something because it really is nice to finally come with something that helps them. But in the PDT days, we were just delaying the visual loss, and so you have to realize that innovation doesn't usually happen all at once. With the great anti-VEGF agents we have now, it usually starts slower, as you mentioned, and PDT did very little in the scheme of things for improving visual acuity, just as this does very little in that regard. But it's a step, and I think we'll make great progress on this stepping stone in the future.
Yeah, I think there's been some criticism regarding visual acuity or vision benefit with this drug. I think it's important to note that in the trial, the large majority of these patients were foveal involving, and they were large lesions, 8 millimeters on average or so. And so I think that if we look at subsets of these patients, I would expect that in smaller lesions and non-foveal lesions, it's probably easier to show vision benefit. In this trial, they did show some vision benefit in terms of microperimetry data with reduced, number of scotomatous points in the 18 to 24 month time period in that junctional zone of lesions. But I suspect over time we may see more benefit too. But I think that the size of these lesions and the foveal lesions may have blunted the vision benefit when we look for it.
I agree. And in addition to this, visual function is difficult to measure in these elderly individuals. These are very noisy tests, microperimetry and others, the BCVA included. Also, these studies were not designed for function as a primary endpoint. In order to do so, Usha Chakravarty and others show using the large UK data set that you need to actually enroll small lesions that are subfoveal so that you still have a little area next to the fovea that you can impact fast in a short study like this. This study was too short to pick up a functional change. We might see it in the extension study in Gale, so we're looking forward to those data. But again, we have a mixed population with 60+% subfoveal. These are large lesions, not those small lesions that you should enroll for function. And then the rest are extrafoveal at different distances from the fovea. So tough thing to measure in this type of study. Would have to have a different design for function as primary.
I would like to ask the panel's thoughts on the competitor company, Iverick's agent, with respect to their recent report of less visual loss of 3 lines or greater in the small subset of patients that had that. Any thoughts on that report? I know their patient mix was extrafoveal and would be, potentially better for showing a visual change than the Apellis group. But any thoughts from the panel?
Yeah, I think that it's encouraging when we see any of these potential functional benefits from these agents. And as you said, they're different studies, and it's hard to make exact cross-study comparisons. Although the Apellis study does have over 400 patients that are non-foveal as well. So they do have a fair amount there. But I think it's important to look at all these, to look at the safety and efficacy of each one, but all of these opportunities to help discern which patients may benefit the most and which patients may not benefit as much from these treatments will be important. And I think both Apellis and Iveric will do a great deal of work to try to understand those outcomes best and figure out how to use those. But I do find it encouraging to see a potential functional benefit, whether it's preventing visual loss or stabilizing vision.
Any other summary comments from our panel?
I just think it's a real exciting time. I will be interested to see the 2-year results from the Iveric study to see if indeed they do show more in the way of visual benefits. And I'm excited to be able to have access to hopefully 2 drugs in this. But it's really wonderful to have a new agent and an untreatable disease after so many decades.
Yeah, I'm really excited also. I think our patients are excited. They've been waiting for this. We have many patients that come in each month asking if the drug is out yet. And it's so gratifying to be able to say, yes, the drug is out, and we may have another one on the way. And so I agree with Bob. This is an exciting time for us, and I think that it's just the beginning in the treatment of GA.
Excellent. Nora?
I agree with Bob also. I feel that the approval of this first treatment for GA was important and historic. And you might have represented, as Dilsher, you said, maybe the end of the beginning, to quote Winston Churchill. It's the end of the beginning of research in this very difficult disease area. So I truly look forward to more therapeutic options that will become available for GA and perhaps earlier dry AMD stages, intermediate, et cetera, in the near future.
Jeffrey?
Yeah, I think just to tack on with what Bob, Dilsher, and Nora have said, this is the first step in a very important path to hopefully getting complete control of this disease. And ultimately, once we learn how to not just slow down, but stop the progression, then maybe some of these new approaches will help us actually reverse some of the vision loss in these patients.
Incredibly important time for us and for patients. We have world experts here on this panel. I'm very grateful. Bob's grateful, and the readership and listening audience will be as well. I couldn't agree more with Nora's comment about we need to begin to move earlier in AMD before there's essentially the house is burned down. Looking at earlier stages of intermediate AMD, and there's a lot of research going on. In GA itself, just to put it in perspective, there's not only Iveric, but there are oral medications, there are gene therapy medications that are being looked at in the Janssen program, in the gyroscope program. There are cell therapies that are being explored, surgically delivered in the subretinal space from the Astellas program, the Genentech lineage program. So we have a lot of shots on goal, but I think one of the important concepts that we should be thinking about in our listeners, our ecosystem, is that we need to start looking earlier in the course of dry AMD. So, Rebecca, do you want to take us home?
Yes, this has been a really fantastic discussion, and I want to thank each and every one of you for joining us today. This concludes our episode on GA Therapy Pearls. Please tune in for future episodes of New Retina Radio.